Hello again, everybody. Today, we're going to be talking about diseases of the skin and the eyes. In line with everything that we've been doing so far, I'd like to talk a little bit about the anatomy of the skin first. All right, there is a picture that I took out of your textbook, and it shows you like a cross section of the skin. You notice that it is made up of a couple of different layers. You have the epidermis, the dermis, and the subcutaneous layer. Now, when we talk about the integument, we're really talking about the skin, the hair, the nails, the sweat glands, and the oil glands, or the sebaceous glands that are there. And if we look at it, we'll talk a little bit about the dermis first. And there's really several layers even to the dermis. There is something called the stratus corneum, the very top, if you notice there. Okay. And that's really made up of dead cells that have migrated from the lower or the deeper layers. They're packed with proteins called keratin. And it's the keratin that gives the cell their ability to withstand the damage, the abrasions, and water penetration and things like that. And then under that, you're going to have a couple of layers, 3 to 4 layers of epithelial cells. The lowest is what they call the basal layer. And that one is attached to the dermis itself, the next layer of the skin. And in the dermis, you notice that there are nerve cells, the blood and the lymph vessels, and the glands. You can see the hair follicles in there. Although they're protruding out, they're really embedded in the dermis. A lot of your glands, the scent glands, are associated with the hair follicles or the roots. And even though they open out or on the skin surface, they started out lower or in the dermis layer. All right, so that's our anatomy, the anatomy of the skin itself. We will learn later on, or we did actually when we were doing non-specific defenses, that the skin is one of our mechanical barriers preventing organisms from getting in there. And one of the ways it does that is by causing the sloughing off of the outer layer of the epidermis. Constantly, organisms that even get to there, they're being sloughed off. And that's one of the ways you are naturally protecting yourselves from organisms getting there. So the next thing we want to know besides the anatomy is how are we defending ourselves from organisms that are trying to invade us through the skin? Well, one of the things, according to your slide here, one of the things would be your antimicrobial peptides that are being produced. And these are things like defensins, positively charged chemicals that act by disrupting the negatively charged membranes of the bacterial cell. And there are many types of these. Basically, their chief responsibility is to keep the microbial count on the skin fairly low. Continuing with the defenses, your defense against skin invasions, turns out that your sebaceous glands secrete something called sebum. And sebum has a very low pH and that will make the skin very inhospitable. It's a deterrent for microorganisms. It also has that oily texture to it due to its high concentration of lipids. And although lipids serve as nutrients to microbiota, they're toxic byproducts after the organisms metabolize these fatty acids. That will inhibit the growth of microorganisms that are not adapted to the skin environment. And then, of course, you have sweat, also inhibitory to microorganisms because of the low pH and the very high salt concentration. So low pH, definitely a deterrent, and high salt concentration, you learn from your MS plate in the lab that only the halophiles will proliferate in high salt concentration. Also, the sweat sometimes have the lysozymes that are capable of breaking down peptidoglycan. And if you remember, peptidoglycan is that unique cell wall material we see in the bacteria. Another part of our defense is really our normal flora. Now, these are organisms that must adapt to living in dry and salty conditions. They are sparsely distributed over the flat surface of the skin, but they grow a lot in moist areas and in skin folds. You find them a lot like in the underarm area and the groin area, and sometimes under the breasts. People people that are heavy set, sometimes they have folds on the skin, and these organisms will grow very well in those folds. Okay, so the normal flora, talking a little bit about what's there, a lot of different hundreds of species of microbes, including some very well-known pathogens, can inhabit the dermis and the epidermis and even some of the subcutaneous layer. It seems like different species favor different areas of the skin, different body parts. And different people seem to have different organisms. An individual's microbiota remain constantly stable throughout the life of that person over time, but can vary. You know, one person's microbiota can vary from another person's microbiota, but they're all there for the same purpose. They are going to help to ward off organisms that are trying to get there, because that's their little niche and they don't want other organisms to be there. Risk factors. How do we acquire these organisms? Well, of course, injury to the skin. Sometimes you have blisters or surgical wounds, a cut or a bruise or an abrasion, insect bites. Anything that causes any injury to the skin will allow organisms to enter. Dry, irritated skin is another good example of a risk factor, because when the skin is too dry, it may crack. And the cracking of the skin will create avenues for the organism to get in. Sometimes you don't have to have any of these things. Sometimes the microorganisms, they're coming in with their own weapons. They're enzymes. Many times they may produce keratinolytic enzymes to break down the keratin and enter your skin. Obviously, the health status, we always say health status of individual is very important. And if the health status is not up to par, organisms can find a way. They gain the upper hand and they will find a way to invade you. Venous and lymphatic insufficiency. Well, we're talking about your circulatory system or your lymphatic system not working sufficiently. And so many times when that happens, especially the extremities, the blood is not getting down to the extremities. And because of that, you have no oxygen in the area. And that is, a call for especially those anaerobic organisms to enter and start causing their damage. Some symptoms of skin diseases? Well, more than likely you're going to have an itch. There are different types of lesions. There are so many, maybe dozen or more different types of lesions that you will learn about, especially if you're a nursing student. They will talk a little bit about the macules and the papules, the carbuncles and the furuncles, nodules, pustules, vesicles, and all these types of lesions. And there are ways to actually differentiate them depending on what they look like, what they contain, and things like that. You will be able to tell them apart. All right, so those are some symptoms. Now, our next job is really to talk a little bit about diseases. Now, I don't want to really get into the diseases right away. I will, but not immediately, because there are a couple of organisms that seem to be causing a lot of damage when it comes to skin diseases. And not just skin disease, but diseases in general. And so I want to talk about these two organisms. And one of them happened to be the Staph aureus. The other one happens to be the Strep pyogenes. These two organisms, it seems like it doesn't matter what kind of diseases, almost look like you can turn around and Staph and Strep will be there. If not the primary organism, it's secondary or mixed up with some other organism causing all kinds of damage. And that is because these two organisms seem to come with an arsenal of weapons. Okay? They have so many weapons that they seem to be able to invade just about anything, any tissue, anywhere, and cause damage. You remember Staph aureus from the lab. You know a little bit about it. They are really gram-positive cocci in clusters. They're generally non-motile. They are halophilic organisms, meaning they can withstand the salt concentration we were talking a little bit about earlier that you find in sweat. But not just as the staph, they can also withstand extremes in pH and temperature and even drying. So they can live on the surface of the skin where you don't have a lot of times a lot of the moisture. So some of the weapons that they produce are listed there. And I would like to talk a little bit about a couple of them. Exoenzymes like coagulase. Coagulase, there is a test on coagulase there. And coagulase is an enzyme that these organisms produce that will cause a clot. I noticed in the same topic, the same example of exoenzyme, you have also a staphylokinase. Now, the staphylokinase is an enzyme that will dissolve the clot. So, doesn't make sense, doesn't seem at first glance anyway. Why is the organism producing coagulase to form a clot and then producing a kinase to dissolve the clot? Well, different times. Chances are they're not going to produce the same enzymes, both enzymes at the same time. Coagulase forms a clot. Now, how is that good for the organism? Remember, anything that's good for the organism is bad for us. How is that good for the organism? Well, when the organism forms a clot around itself, it's almost like a protective mechanism. Remember when we talk about capsules, we say capsules forming around the organism will increase the pathogenicity of that organism. And it is true. If there is a clot form around the organism, two things can happen. Number one, the organism can very safely multiply in that clot. And you know there is always strength in numbers. Number two, when the clot is around the organism, then it's more difficult for the white cells to engulf them. You're deterring phagocytosis. So the organism is safe from being phagocytized. Good for the organism, bad for us. So let's talk a little bit about the staphylokinase. Why is that good for the organism and bad for us? Well, different occasion, different scenario. If you have a cut, chances are you're going to bleed, but you're not going to bleed forever. There is that natural mechanism that you're going to form a clot first, and then eventually it will heal. That clot is there for a reason. Actually, two good reasons, I should say, among everything else. The clot is going to block the blood vessels so you're not bleeding constantly and forever, number one. And number two, it's also blocking organisms from getting into the bloodstream. That's a clot that you're forming. That's protective for you. Now, if the organism now can come around and produce the staphylokinase to dissolve that clot, the barrier that you're creating for yourself, then the organism can now, once dissolve the clot, can enter the system and cause the damage. So it may sound like it's doing that for the organism, but no, two different occasions. Then, of course, we talk a little bit about hyaluronidase. If you remember, that's the enzyme that will destroy hyaluronic acid. And hyaluronic acid is the cementing material between your tissue cells. So if you can destroy that cementing material in between the cells, of course, the organism can invade and get in between your cells to cause the damage. And then, of course, you have all kinds of other enzymes like leukocidins that will, of course, attack your leukocytes, your white cells that are there to protect you from them. They can kill them. Okay. And then you have lots of proteases that may be responsible for destroying those antimicrobial peptides we talk about that help you out in a couple of slides before now. The other thing we talked also about was enterotoxin. Remember when we were doing the gastrointestinal diseases, I mentioned that you don't just have to contaminate yourself with microorganisms, but you can actually ingest the toxins. And Staphylococcus produces a powerful enterotoxin also. And then you have other things like hemolysins. A lot of your Staph aureus will be beta hemolytic, toxic shock toxin, and exfoliative toxin. And the names will tell you. Exfoliative toxin cause your squamous epithelial cells to just peel away. We'll talk a little bit about scalded scale syndrome. And you'll see the picture where it's like the skin is just peeling away because of these toxins that are produced. The other organism is very similar to this one, the Streptococcus pyogenes. We did talk a little bit about Streptococcus pyogenes in, I think, when we were doing pharyngitis. It is your group A Streptococcus. And if you remember Streptococcus, a little bit of what we did with strep in the lab, Streptococcus, they are generally gram-positive cocci in chains. Okay. And like this, they're generally non-motile. There are many different species, and all of the ones that are beta hemolytic are generally pathogenic organisms. Like the staph, they produce all kinds of enzymes and toxins. So they're coming up with their arsenal of weapons too. And you have exoenzyme like hyaluronidase, we just talked about. I had mentioned streptokinase earlier when we were doing non-specific responses. And just like the staphylokinase will dissolve your clot, the streptokinase will come and do the same thing. Hyaluronidase will do the same thing, increase the permeability, their increase their invasiveness into your tissue cells. And then, of course, they're all beta hemolytic, hemolysins. So they're coming up. These two organisms seem to be the ubiquitous. In the case of the strep, we talked about not only their arsenal of weapons, but they can produce some lasting damages after their primary infections. If you remember, when we talk about pharyngitis, we talk about the sore throat, yes, pharyngitis, but if not properly handled, you could end up with things like scarlet fever and rheumatic fever and glomerulonephritis. So these are the organisms that we got to be very leery of. I chose to talk about these two organisms because now that I spoke about them, we can talk a little bit about diseases of the skin. And believe it or not, there are some diseases that are attributed to both of them. For example, let me see, I think I have one slide here. Necrotizing fasciitis. If a person has this disease, you can see how devastating it is. For those of you who ever heard of the flesh-eating bacteria, it's usually the strep pyogenes. But you're not going to get this necrotizing fasciitis with strep pyogenes alone. 95 out of 100, almost always. Staph aureus is also involved. Okay? You may have one or the other or both causing this damage. Because remember, when I talk about their arsenal of weapons, they're about the same too. Just as dangerous. And if you notice what's happening here, that's why they call it the flesh-eating bacteria. They're damaging this, they're spreading the infection in the connective tissue, and then the overlying tissue will die. And it keeps on spreading. And you need to actually debride. Debridement is often necessary. And that's what they did to this patient that they're showing you there. Of course, once you try to do that, then you have to deal with making sure you get rid of the organisms, antibiotic therapy, among everything else. Impetigo is the next thing. Staph aureus or Streptococcus pyogenes, highly contagious. And if you notice, it's that exfoliative toxin I was talking about. The skin is peeling off, and you end up with this kind of ulcerated lesions, dry, patchy lesions that you have there. Another reason for that exfoliative toxin, erysipelas, strep pyogenes. It's a subcutaneous infection. organism entering very small breaks in the skin. Sometimes you don't even know you have them, and causes inflammation. And this can spread almost throughout the entire body. Of course, all the infections, the bacterial infections I'm talking about, we can easily treat with antibiotics. A lot of them are not resistant to antibiotics. Of course, there is more and more resistant to antibiotics these days, but as the organisms try to protect themselves by developing the resistance to antibiotics, pharmaceutical companies are trying to come up with ways to counteract that too. And many times doctors use combinations of drugs that will be synergistic. So we're able still, fortunately, able still to treat these infections. Scalded scale syndrome, usually caused by Staph aureus. Exfoliative toxin, again, causing the skin to just peel. Squamous epithelial cells are just kind of no longer there. Skin is just sloughing off. And when that happens, of course, then you have secondary infections, other organisms. You see, your intact skin is very protective to you. But if something is happening to that intact skin, other organisms are trying to get in there and causing damage, like you're seeing on the slide. Of course, it makes room for other organisms, including your own normal flora, to go in there. Because I told you, the normal flora of the skin could actually be some pathogenic organisms, some really well-known pathogens. So if they are on the skin, and now you're making the skin more accessible to these organisms, of course, you're going to have secondary bacterial infections. Now, your book has a long discussion on MRSA. I guess because it is something that you, preparing to be a nurse especially, will want to learn about. And so we'll talk a little bit about MRSA, not the disease itself, but a little bit about the organism. Now, it is staph. So all the things we know about staph, being a gram-positive cocci, being growing in clusters, okay, withstanding the salt concentration, extremes in pH and high temperatures, remains viable even after drying. And because of that, it can resist many of the disinfectants and antibiotics they have around in the market these days. So that's the characteristic of the staph itself. So what makes it the MRSA? Well, at one point, methicillin used to be one of the drugs of choice for treating staphylococcus infections, because this organism, for some reason, is generally not going to respond to things like ampicillin and many of the penicillins, first line penicillin, ampicillin, and so on. But axicillin used to be a good choice, and methicillin is a very similar drug. Then all of a sudden, these organisms, the staph, this particular strain, start developing resistance to common types antibiotics, including axicillin and methicillin. And so they call them the methicillin-resistant Staph aureus. Okay, so your book goes into a lot of discussion about it. It would be nice if you can get to your book and listen into that, read about the discussion, talk a little bit about it. right? But what I'm saying is that this organism, if we want to learn a little bit about it, not the disease they cause, but I told you staph could be just about everywhere. It's almost like that ubiquitous organism I'm talking about. But how you get it, the transmission and the epidemiology is important because this organism can contaminate. It's a contaminant on just about any surface. Because if you have staph on your skin, chances are you're going to find staph all around your house. You sit on you sit somewhere in your house, on your sofa, on the chairs. You put your hands on your tables and whatnot. You lie in your bed. Your clothing, everything is contaminated with this staph. So it's there. You go to the gym. People are touching the gym equipment. They're transmitting organisms or contaminating the gym equipment. They talk about airplane tray tables. Nobody's disinfecting those things after you leave. Maybe once in a while, but not all the time. So it's just about everywhere. And so if you know that your staph, whatever is on your skin, is one of those multi-drug resistant staph, then you need to be very careful so that you don't transmit it to other people around you. And that's how people get it. Many times you may have it and don't even know, but if you do, one of those resistant staph, you got to be very careful. All right. Toxic shock syndrome is one of those diseases. Well, it's caused by the Staph aureus, and the organism produces a toxin, which is considered to be like a super antigen. And the super antigens, maybe I didn't go into the details of the super antigens when I was doing your specific immunologic response, but they will elicit a massive immune reaction. Lots of cytokines and chemokines, and they will end. Persons will end up with fever and nausea and diarrhea and vomiting, and it's not something that's specific. A lot of these super antigens will do the same thing. So you need to be able to differentiate and do some what they call differential diagnosis. So you know what you're dealing with and you're treating the right disease. If you remember, toxic shock syndrome was I think that was something that was very prominent a couple of maybe 10, 15 years ago. And it was attributed to using tampons, I think, contaminated tampons. So women were getting contaminated with this organism. Here we have gas gangrene. And gas gangrene or gangrene itself is caused by an anaerobic organism, Clostridium perfringens. Now, this organism is spore forming, and I might have mentioned about a little bit about this organism when we did the spore stain in the lab. Many times you have these spore forming organisms, and the spores are found, mostly in the soil. Your wounds get contaminated from soil spores that are found in the soil. And you would think, well, it's an anaerobic organism. Every cell in your body can be reached by oxygen because you have blood flowing to just about every cell. So why can we have, or why do we have organisms that are anaerobic and still take hold in our system, in our tissue? Well, it just so happened that we talked not a few slides before now, that there are times when there is circulatory insufficiency. The blood vessels, or I'm sorry, the blood is not reaching the extremities. And when that happens, and you're not aerating the extremities, especially the extremities, then anaerobic organisms can take hold. So it's not that. Apparently, I would venture a guess that this patient is probably a diabetic patient with circulatory insufficiency. And once you get a wound, and that wound is contaminated with this organism, the organism just takes, it's almost going to spread like wildfire in the system. It might have started out really at the ankle there, and look where it's gone right now. And I guarantee you that if they amputate even below the knee, that's not good enough. I have a feeling this person's whole leg is going to have to go. If it wasn't that badly damaged, maybe they leave a little kind of a stump right under the knee. So in case you want to use a prosthesis of some sort, you'll be able to do that. But I don't think it's possible in this particular case. Amputation is a must. And there are other bacterial infections. We talk a little bit about Pseudomonas aeruginosa. It's one of the organisms we use in the lab sometimes. And that organism is very prominent. It's one of the first organisms you'll cultivate in burn victims. Seem to be opportunistic, but the minute the skin is damaged, it just takes over. So we find Pseudomonas a lot in our burn victims. And then we have Bacillus anthracis. Remember, this is the organism that causes anthrax. We talked a little bit about Bacillus when we were doing, I think, also the spore stain. We talked about the anthrax bacillus, and we also talked about cutaneous anthrax. So we have pulmonary anthrax and cutaneous anthrax, the wool sorter's disease. We talked about people, especially, if they are working with sheep and goats, the farm animals. In England, where a lot of people are hired, certain parts of the year, they hire people to shear the wool off the sheep. They can get infected very easily if the sheep is infected with the Bacillus anthrax, and they end up with a skin infection that we call cutaneous anthrax. And then we also talked about Microbacterium leprae causing leprosy or Hansen's disease. We did that one when we were doing the AFB, the acid fast staining in the lab. Okay, and this is the organism, and the Mycobacterium tuberculosis would live in the deeper, the core of the body, in the lungs, and will tolerate deep body temperature. This organism, like the cooler parts of the body, like the peripheral area and the skin, which is cooler than the core body temperature, grow there very well. Another thing I'd like to mention as a group is a group of viral diseases that caused a major symptom being some sort of a skin rash. And measles happened to be one of them, also known as rubeola, caused by a virus. And although it may seem like measles not that big a deal in the United States, at one point it was like 385 children will die per day of this disease. Vaccination came around. Okay, but before then, measles kill about 6 million people every single year around the world. Not in the United States alone, but that the 6 million will be around the world. Since the vaccine, deaths have been greatly reduced. There are times, I should mention there, that there are some parents who are opting not to vaccinate their children because it's been going around this unfounded fear that there's a link between the vaccine and autism. So you have nowadays, mothers are so scared to take their children for the vaccination, not just measles alone, but they'll tell you they don't want their children to be vaccinated because of this fear they have in them. Chickenpox is that other disease I'm talking about, varicella, and it's caused by the varicella zoster virus. All these, they may present themselves as skin diseases because they're so, look at all the different rashes that you can find on the skin. But yet for all, they are transmitted basically through the respiratory tract and disseminated that way. Okay? So here is what chickenpox would look like. And notice that it does vary, whether the rash, the location of the rash, size of the rash, it does vary with the individual. And remember, this is the chickenpox virus that would later, they talk a little bit about shingles, I think, in the next slide. Okay. Here we go, the shingles, which is the reactivation of that virus. It seems like the virus, it becomes dormant, it stays there in your skin, and sometimes years later, you may have the disease as a child, and then as an adult, you end up with shingles. So they're advertising, I think they're advertising a lot these days about vaccination for the shingles virus. Smallpox. Now, I don't know if you remember, maybe you are not old enough to remember smallpox. But smallpox used to be one of those scourges. It was eradicated worldwide in 1977. Last case was in Somalia. And here is an organism. Look at some of the skin rashes that you see. Very large vesicles, almost like pustules. And it seems to take over the entire body. Individuals, you might start out with a small, flat, red discoloration, and then you end up with a papule or whatever it is. There are different forms of this virus. So it can evolve into macules and papules and vesicles and pustules and whatever they call them. But if you recover, a lot of people die because it's 50% fatality when it was around. If you recover, you ended up with lifelong immunity. You have that blistering rash they talk about. So I think when we had the disaster the World Trade Center disaster. And they were talking about bioterrorism. That was one of the problems they were discussing, because they were thinking that nobody is vaccinated. They don't give smallpox vaccination anymore because nobody has it. It might be a target for bioterrorism. And so they were talking again. They brought back to the table a talk about vaccinating people for smallpox. I don't know if that ever gets off the ground. There is something called the fifth disease, erythema infectiosum. The reason why they call it the fifth disease, it's because doctors were so used to those four that we just mentioned. The measles, what was it? The measles, the chickenpox, measles. Then we have chickenpox. We have the shingles, the smallpox. And now we have the fifth disease. It is one of those diseases, very much like the others. One of them mimics scarlet fever, but I don't think it's scarlet fever. It mimics the others where the rashes are concerned, but it's still a little different enough to realize it's not the same as any one of the other four. And so they end up calling it the fifth disease. Symptoms are there, and you do end up with the rash. It looks like what they call the slapped cheek appearance that begins on the face, but it can spread throughout the body. So when I say slapped cheek, it looks like somebody slapped you on the cheek on both sides, and it becomes very red, discolored, but that will just permeate the rest of the body within a short period of time, within 2 days. Caused by the paravovirus, but nothing much more to say about that. Leishmaniasis is another skin disease. Well, Leishmania donovani causes a very severe form of leishmaniasis, which is attacking the viscera, visceral leishmaniasis, they call that one. But there's a milder form caused by Leishmania tropica, which is the skin leishmaniasis, cutaneous leishmaniasis, and it's transmitted by the sandfly. Most of the time you will find it's endemic to Central and South America. And I might have mentioned when we did the protozoa that, especially in Central America, you have a lot of these individuals contracting the disease and end up with skin or cutaneous leishmaniasis. I don't think I have a picture to show you what those look like, but dry ulcers on the skin. Fungal infection of the skin. If you remember, we talked a little bit about the two types of mycoses. You have systemic mycoses and superficial mycoses. And when we talk about superficial mycoses, we're really talking about the infections of the skin, the hair, the nails, things like that. And many times we're talking about 3, possibly 4 genera. Dermatophytes, those organisms that produce the enzyme to digest the keratin, belong to the genus Trichophyton. If you go back to your fungus slides, I gave you some species too. Trichophyton mentagrophytes, or Microsporum, maybe gypsium, Epidermophyton flocosum. These are the dermatophytes. And they are the ones that will cause superficial mycosis. Sometimes you have something called malassezia. Malassezia furfur sometimes invade the scalp. At one point, that was thought of the disease, the organism that causes dandruff. But now we know it's basically a skin disease that causes the scalp to just flake away that looks like dandruff. So those are some of the fungal infections of the skin. All right. So we did a little bit of the bacteria, the fungus, the virus. Can't think of any protozoa that actually invade the skin. Now the eye. The eye, I have there a slide showing you the anatomy of the eye. And there is, I'm sure you learn a lot more about the eye in your anatomy classes. But the eye, you can think about as most of it kind of hidden from the external. It's not exposed. A lot of the eye is hidden. But it is one of those portals of entry for organisms. All right. I'm not going to go into the anatomy of the eye, the eyelid, the pupil, the sclera, and the iris. Those should be second nature to you. The conjunctiva is one of those areas that is very commonly hit by organisms. So let's talk about the eye when it comes to what might be some of your defenses. Now, first of all, you know that there are lacrimal glands that will create or produce a lot of tears. Tears is one of the defenses you will have. Tears contain things like an aqueous fluid, there are oils, even mucus in the tears. You also have things like lysozymes and lactoferrin in tears. All these are protective material. Every one of them is protective against microorganisms. So tears happen to be a very good defense against microorganisms. Then, of course, you have mucus in the conjunctiva. And mucus is there. All your mucus membranes, they're there for a reason. The mucus that is secrete will trap microorganisms and try to get rid of them. And then we know that the flow of tears, the blinking of the eye, and the flow of the tears will prevent organisms from attaching to the eye. And I'm sure you experienced it. If there is any problem in the eye at all, you're going to start to tear profusely. Anything that gets into the eye, you're going to start to tear in an effort to wash organisms back out, or anything foreign will create that sensation and force the tear glands to start producing the tears. Of course, you're going to have normal flora too. Sparse, but they're there. A lot more than was normally thought of, but a lot of organisms that are generally found on the skin, you can find them around the eye, not in the eye itself, but around the eye, because the skin is so closely, connection is there. So things like Staphylococcus, Corynebacterium, Streptococcus, they're all in that vicinity. And again, they occupy that little niche that will try to deter others from invading the area. Staphylococcus, Streptococcus, Corynebacterium, yeast. Some species of Neisseria, they're normally found in the skin, normally microbiota of the skin. They will also be found in areas around the eye. Conjunctivitis, inflammation of the conjunctiva, is a relatively common occurrence. A lot of organisms have that predilection for eye tissue. And a lot of times, the reason for getting the conjunctivitis in the first place is self-contamination. You have a person with contact lens, and many times they take the lens, I think, on a daily basis. They remove the lens before they go to sleep, and they put them back on in the morning. And if they're not careful, the mere fact that you have to do it on almost like a constant basis, the mere fact that you have to do it is a problem. And so to decontaminate yourself before you put your contact lens, especially when you're in a rush, you don't generally want to take the time to do it. Of course, if there is eye injury or accidental inoculation of the eye with something that's going to cause trauma to the eye, will expose the eye to organisms. And one of the first things that will happen will be the conjunctivitis. Now, when we talk a little bit about rickettsial diseases, we talk about chlamydia trachomatis, that will invade the area. That organism has a predilection for the eye tissue, and it will cause eye damage. It starts out with a conjunctivitis, but if left untreated, will certainly invade the ligaments and all those things holding up the lens together. And before you know it, the lens is falling off and individuals will become blind. All right. In the case of conjunctivitis, you end up with like a milky discharge. Some viral infections will give you clear, watery exudate. And maybe you've heard about this, or maybe it happened to you. Maybe not now, but as a child, where you had a problem and you're sleeping at night, you wake up in the morning and your eyes are glued shut by secretion. And you really have to carefully try to get the water to wash it off before you slowly open your eyes. Nowadays, a lot of conjunctivitis could be due to an allergic response with that clear watery fluid. You see, when people have allergies, you notice that their eyes water a lot. Sometimes they even look like pink eye. And you can almost tell that, kid around sometimes and ask them why they're crying or anything like that. But that is one of the things that will happen. Well, conjunctivitis in the neonatal, the newborn babies. We talked a little bit about Neisseria gonorrhea, that the baby's eyes could be contaminated if the mother has Neisseria gonorrhea in the vaginal tract. And many times, the organism invades the baby's eyes. For those of you who don't know, every baby that is born in the United States, I think the law is you have to clean that baby's eyes up with some kind of an antimicrobic substance. For the longest time, they used to use silver nitrate solutions. And years, they used to wash the baby's eyes with silver nitrate solution. Some hospitals, I think maybe it's not mandatory to use silver nitrate, but mandatory to make sure you clean the baby's eyes. One hospital I know, one of my students working in the hospital, told me at one point that they had changed to erythromycin ointment, but that didn't seem to do the job as well as the silver nitrate, so they had gone back to silver nitrate. So I guess it's optional as to what you want to use, depending on the hospital itself. For those of you who are working in a hospital setting, maybe you can tell me what is it that your hospitals are doing these days. So I'll have an idea of who is doing what. Okay, so these organisms, and I talked a little bit about Chlamydia trachomatis, these organisms are vertically transferred from the mother to the baby, and especially Neisseria gonorrhea, not belittling the other one either, but they can cause serious eye damage if not treated promptly. Because remember, the baby is still newborn, and the eye and everything is like very fragile at this point. The baby hasn't developed its own immune system yet, and so can succumb to a lot of these organisms. All right, let's see. Prevention and treatment. Well, here they talk about using Cipro to treat the infections because it seemed to cover all the possible bacterial infections. Sometimes physician may prescribe prophylactic antibiotic eye drop. And that is probably for individuals who develop later on conjunctivitis. And of course, if the symptoms don't improve, you got to go back and figure out exactly what's causing the problem and then try to treat. Keratitis. Keratin, the layer of the skin, can be destroyed by some of the organisms. And this is the invasion of the deeper eye tissues that can result in blindness sometimes. Herpes simplex virus is a culprit where that sometimes you get during delivery, you can get that, but a lot of times you get that disease later on. I might have mentioned when I did the protozoa about acanthamoeba keratitis. Here is an organism, acanthamoeba, that is one of the Sarcodina type organisms. And this one here, they generally don't form the cyst because they are free living organisms they live in ponds and freshwater lakes and sometimes swimming pools that water hasn't been changed for a while. You can find them there. And when you go swim in these lakes and ponds and pools and whatnot that are contaminated, of course, it enters the eyes and can cause severe conjunctivitis and keratitis. Again, can be a problem with contact lens. So contact lens can be a huge problem for people who don't want to wear glasses and insist on contact lens. I was thinking of another organism, I think Naegleria fowleri, which is another protozoan that could cause keratitis and also found in freshwater lakes and ponds and things like that. And almost the same way you can get the acanthamoeba, you could get the Naegleria also. I have a feeling it's almost the same treatment, usually flagell. All right, so that is my little spiel on organisms of the skin and the eye, I'm going to stop my recording and we will continue with lectures the next time.